Welcome everybody to this MDS roundtable. My name is Guillermo Garcia-Manero from the Department of Leukemia at the University of Texas MD Anderson Cancer Center. And I'm very pleased to be here today in this teleconference. Before we go into the last couple of questions, I would like to, this is something that I see in my practice a little bit, where some of the physicians that are not very familiar with Luspatercept or they're starting to use it, they struggle with this issue of the dose kind of escalation schema that we use. So I don't know who of you would like to remind the audience, how do you use the drug and how you go from the 1 to the 175 and so forth? Any of you, please.
Yeah, I can just go through that quickly. I mean, we always have to remind people that you don't give this therapy any closer than 3 weeks together. You generally give at least 2 doses at each dose level before you're ramping up. So you're starting at the 1 per kilo. You can go up to the 1.33 after you've gotten 2 doses if you're still requiring transfusions. After 2 doses at the 1.33, you can go up to the 1.75 per kilo and then give at least 3 doses of that before you're making kind of final judgment on whether or not the therapy is working. But also have to remind folks that transfusion independence is actually not the only meaningful endpoint with this treatment. So that's what you're looking for at the starting dose level and the intermediate dose level, assuming the patient's tolerating the treatment and not having any high-grade AEs. But especially when you get the maximum dose level, not everyone will be transfusion independent, but some of those patients will have meaningful improvements in their hemoglobin or reductions in the number of red cell units or frequency of transfusions needed or both, which, like we talked about earlier, can make those patients' lives easier. And then it also helps us with reducing iron overload from transfusions. So if you're seeing, the gram of hemoglobin increase, but the person's still needing some blood, maybe they're needing less blood less often, you can and should still continue the therapy at that maximum dose level as long as they're tolerating it well. So those are some of the things that I try to remind folks of. And I do unfortunately see a lot of people start this therapy and either never dose escalate or stop it after 3 or 4 doses, maybe only go up 1 dose level, especially if the patient maybe has some mild to moderate symptoms up front and kind of prematurely abandon it, which is sad when we have too few therapies already for these lower risk MDS patients.
Yeah, I totally agree with you. Thank you very much for such a clear answer to that.
One difference with EPO that I think is important that that we have to share is that with EPO we don't start it until your hemoglobin is less than 11, whereas with Reblozyl I believe it's 11.5, and then if your hemoglobin goes above above the threshold or 11, I mean. Well, first of all, I guess that's most important. Basically, is that your cut point is 11.5 as opposed to 11 with EPO.
Solly was talking a little bit about this, the dosing and the 11.5 and things like that. So this has somehow the schema irritated a little bit European colleagues. So they designed a study called, I think it's called Maximus, something like this, where they're asking about why it would be wrong to have 13, 14 grams of hemoglobin instead of 11. And it's actually 1.75 the right starting dose. Of course, these doses were based on FDA safety guidelines, and we need to respect and appreciate that. But, I don't think we've seen a lot of cerebrovascular type of events, and you could argue actually that one could be a little bit more aggressive in terms of the doses and perhaps, allow for higher hemoglobin levels that Stone was saying probably will be better in terms of the well-being of our patients. So we'll see what happens with that study. It's going, I think, only in Europe, but I think this is really exciting times. And for people like me who thought about MDS always from like the excess blast, these kind of things, all of a sudden all the progress is coming from the other side in the treatment of cytopenia. So it's very interesting. I don't know if you guys want to have any last comment. And with that, thank you very, very much.
I'd be a little careful about using Luspatercept over 11.5. When it was used for beta thalassemia, and they were allowing hemoglobins to go up to 12.5 and I think even 13, they had a slightly increased signal for some thrombosis. But below 11.5, they didn't have that signal. So that's why. So giving it when it's less than 11.5, and even when you have to hold it, you wait until the hemoglobin goes above 11. I think that's how the think that's how the command study, at least that's how it's in the package insert.
And
they're doing it.
And of course, we'll have zero tolerance for toxicity in low-risk disease. I mean,
Yes,
but
sir.
the studies in Europe, we'll learn from them, and we'll see what happens with that. Thank you, Solly. Tom?
Yeah, I'm excited about that study going right to the maximum dose level because, that's one of the issues that we see with maybe inappropriate use of luspatercept, where people are throwing away the drug before it potentially helps the patient because they're not following the dose escalation schema. So if we could safely start at the higher level, that would be fantastic because it would just make the drug easier to use. But I have kind of doubts about it from the standpoint of the initial AEs that you sometimes see when you start this therapy, but we'll have to wait and see.